Hello, this is the first video on male reproductive anatomy and physiology. There's going to be two parts to this series. The first part will focus on mostly a review of the male reproductive system, go over the major organs, look at the testes in detail, look at how sperm is generated and passed through the different duct system, and then look at the accessory glands like the prostate and the seminal vesicles and so forth. And then we'll end the discussion on the physiology of erection and ejaculation. And then in the second part of the videos, we'll look at steroid physiology, so look specifically at testosterone and male sex hormones. So for some of you, the first part might be a review, and so you might want to quickly skim through that. For others, you may want to be sure that you review the first part so that you're familiar with all the relevant terminology and the relevant structures that we'll be focusing on more with the physiology, and then we'll talk more about that in the pathology section. So just quickly to kind of review all the relevant organs here. The first would of course be the testes, singular testicle. The functions are twofold primarily. One is to generate sperm, and that process is known as spermatogenesis. And the other is to generate steroid hormones, in particular the androgens, testosterone being the largest. Androstenedione and DHEA, though, are also produced in the testes. And that process is steroidogenesis. And then there's a duct system where sperm is carried, and that includes the epididymis, the ductus deferens, or also known as the vas deferens, the ejaculatory ducts, and the urethra. So if you look at the pathways, we start down here with the, draw it in red, with the testes, and then all of the sperm will collect in the epididymis, and then from there pass into the vas deferens. And the vas deferens is going to loop around. It's going to actually loop over, which you can see more clearly in the picture down here, over the two ureters passing into the bladder. And then it's going to loop behind, go behind the bladder, and then pass into the prostate, which sits right below the bladder. And then from the prostate, it joins the urethra. And this part of the urethra is called the prostatic urethra. And then it's going to go into, the sperm will then flow into the urethra, and then down into the penis, and then out. So that is the duct system. And then there are accessory sex glands, which are going to put lubricating fluid, different enzymes, different nutrients into the spermatic fluid. And that includes the seminal vesicles, which are located behind the prostate. That includes the prostate itself, and then little glands not shown here underneath the prostate called the bulbal urethral or Cowper's glands. And their function really is to produce semen. Semen itself, we have to be very clear, is not just sperm. It consists of sperm, about 10%, and the rest of semen, about 90%, are the secretions, and that would be the seminal fluid. And then there are supporting structures. The scrotum supports the testes. We'll look at that here next. And then there's the spermatic cord, which carries the arteries, the veins, and the nerves and the lymphatics from the abdominal cavity down into the scrotum to supply the testes. And then the penis itself is considered a supporting structure. So first, let's look at the scrotum here first. The testes are found within the scrotum, which literally translates as bag. The scrotum, the best way to think about it is that it's an extension of the abdominal wall. So if you look at the embryologic development, the testes actually develop way up by where the kidneys develop, and they migrate downward. And they follow this band of fascia known as the gubernaculum. So the gubernaculum is going to help guide the testes down through the abdominal wall. And as the testes descend, they're going to essentially have components of the abdominal wall wrapped around them. So the most immediate layer around the testes will actually come from the peritoneum, and it starts off as something called the processus vaginalis. And that's going to become the tunica vaginalis, which will surround the testes. Just as a little aside, you might have heard the term hydrocele. A primary hydrocele happens when fluid accumulates within the tunica vaginalis. Usually that's because embryologically some of the processus vaginalis didn't degenerate, and it maintains a connection with the peritoneal cavity, so peritoneal fluid can actually flow down that. So that's the processus vaginalis, and the different layers of the abdominal wall become the different layers of the scrotum. So let's go through that here. So there's essentially 5 different layers. So if we start from the outside in, we have the skin, of course, is the first layer. And this is thin. It contains a lot of elastin. It's pigmented, and it has a lot of folds called rugae. There's no subcutaneous adipose, and that's important because that's going to actually help keep the temperature of the scrotal sac lower than the rest of the body. So that's going to be one mechanism that the body uses, is by not having fat there to keep the temperature lower. The cavity, the testes, have to be kept at a temperature of around 35 degrees Celsius, which is about 95 degrees Fahrenheit, so a little bit colder than normal body temperature. And that's going to be important for proper sperm development in the testes. The skin has numerous sebaceous glands and sweat glands, and their pigment cells as well. Lots of hairs with nerve endings, so it's quite sensitive. And then there's a medial ridge called the raphe or seam. The scrotum itself, I'll just say, in females actually is analogous to the labia majora. So those are analogous structures. There's the next layer in from the skin is the dartus muscle, and that's actually under involuntary control. It's smooth muscle via sympathetic fibers, and that's derived from the abdominal superficial fascia. And this also is going to help regulate the temperature of the scrotum by pulling the testes up or down. The next layer in is the external spermatic fascia. So if we look over here at the picture, we have the skin, the dartus muscle, the external spermatic fascia. That's derived from the abdominal external oblique muscle, and this is a prolongation of the fascia from what's called the superficial inguinal ring. I'll go over the inguinal canal here in just a little bit. And then the next layer in is the cremasteric muscle and fascia. And this also is under involuntary control. It's made of skeletal muscle, and it's derived from the abdominal internal oblique. Extends from the superficial inguinal ring, and it helps pull the testes towards that ring when necessary. So again, this is going to be a third mechanism to assist in the testicular temperature regulation. And then finally, there's an internal spermatic fascia that extends from the deep internal inguinal ring. The inguinal rings, really, we'll look at them. The deep inguinal ring is the ring that essentially is going to form from the inner part here. If we look up at this diagram here, it's going to form, the deep ring is going to be up here, and essentially that's going to allow the spermatic cord and the testes to descend through from the abdominal cavity. The scrotal cavity itself is split into 2 halves, a right and left, separated by the scrotal septum, and that's going to be right underneath the raphe that's seen on the surface and on the skin. And each half contains a testis, a singular testicle, the epididymis, which is where the sperm will collect, and then the lower part of the spermatic cord, which contains the vas deferens, as well as arteries, veins, and nerves. The dartus muscle extends into the septum itself. Okay, and then the scrotal temperature itself, I mentioned, is a couple of degrees centigrade cooler than the core body temperature, so about 95 degrees Fahrenheit versus the classic 98.6 body temperature. And this is important again for proper sperm development. There's a network of veins. This is called the pampiniform plexus, which is found in the spermatic cord. You can see it here. And the pampiniform plexus is essentially going to drain all the blood from the testes. So testosterone, everything that'll be produced in the testes will pass through that. But this series of blood vessels here acts as what's called a countercurrent heat exchanger. And that's going to exchange heat between the arterial and venous blood. That also cools the testes. So this will be a fourth mechanism to maintain the proper temperature in the scrotum. So the pampiniform plexus, the lack of adipose in the skin, under the skin of the scrotum, and then the cremaster and the dartus muscle, all of these help maintain the right temperature. Now, importantly, if there's an elevation of temperature in the scrotum, this can affect the production of sperm, spermatogenesis, but not the production of steroids, steroidogenesis. So even if these mechanisms are not functioning, usually steroid production is unaffected. Um, there are many nerves. There are actually somatic nerves, there are parasympathetic nerves, and sympathetic nerves. We'll go over those as we go through the different structures. The parasympathetics are largely derived from the pelvic nerves, and it's actually S3, S1 and S3. And then the sympathetic nerves are usually branches of the hypogastric nerves, or they travel with the lumbar plexus as part of the genital femoral nerve. So that's, in a nutshell, the basic structures of the scrotum. So just think of the scrotum as really a protective sac for the testes. Each testis actually is at a different level in the scrotum, and one of the arguments there is that actually in the event of potential compression, the testes won't actually rub directly against each other. So found within the scrotum are the testes. Again, singular is testicle or testis. These are homologous to the ovaries in females. They're paired. Each one weighs about 10 to 15 grams. Embryologically, as I mentioned before, they develop near the kidneys. They're retroperitoneal, so behind the peritoneal cavity. And they descend into the scrotum through the inguinal canal during the latter half of the 7th month of fetal development. They may not, however, descend properly. Again, the gubernaculum is the sort of fascial tissue that the descending testes follows. Unfortunately, the testes can become trapped at different places along that pathway of descent, and this can cause cryptorchidism, or hidden testes. This is where the testes don't descend properly. It can be where the testes are actually way up in the abdominal cavity. They could be anywhere along, though, that embryonic path of descent. This occurs in about 3% of full-term infants and in 30% of premature babies because there just hasn't been enough time for the testes to fully descend. Unfortunately, with untreated bilateral cryptorchidism, this can result in sterility because the temperature of the testes will be kept at abdominal temperature, which is much higher than the normal scrotal temperature, again, of 95 degrees Fahrenheit. This unfortunately also increases the risk of testicular cancer. So cryptorchidism, usually if the testes do not descend by the end of the first year after birth, is usually corrected surgically. Usually, though, most of them will descend spontaneously in the first year, and but again, after that, surgery can be used as an option to either remove or maybe attempt to guide the testis down. Usually, the testis is just removed. So that's cryptorchidism. A little bit more on the anatomy of the testes. The sort of layer of tissue around the testis itself is a remnant, or it was derived from that processus vaginalis, which is actually part of a remnant of the peritoneum, and this is called the tunica vaginalis. And that's going to form again during the descent of the testes. Essentially wraps itself in this tissue layer. Again, a hydrocele is a collection of fluid within the different layers within the tunica vaginalis. Hydrocele can be either what's called a primary hydrocele, which means usually this comes from a problem embryologically, where the tunica vaginalis still has connections with the abdominal peritoneum, and peritoneal fluid can actually come down and collect in there. Or it can be a result of trauma or injury, or maybe a cancer, testicular cancer, and that would cause what's called a secondary hydrocele. Hydroceles, we'll talk about those in the pathology section, are pretty easy to spot clinically, and they transilluminate. Actually, if you put a light against the scrotum will actually light up, and they can be quite large. I've seen hydroceles the size of grapefruits or even larger, and they can be quite uncomfortable and painful. They're not cancerous, although they can be associated in rare instances with cancers, testicular cancers. But the primary ones sometimes just reabsorb on their own, or there are different surgical techniques that can be used to correct that. The tunica albuginea is underneath the tunica vaginalis, and this extends inwards, forming little compartments called septa. And the septi actually divides the testes into lobules, about 200 to 300, and each lobule contains between 1 and 3 seminiferous tubules. And the tubules, think of them as a coiled tube, which is where the sperm will be produced. and that process again is known as spermatogenesis. There's about 400 meters of tubules in each testis, so these are really long if you actually lay them out and extend them. Within the seminiferous tubes, there are the cells known as Sertoli cells. You can also call them nurse cells. They actually help the production of sperm. And then there are the stem cells, the spermatogenic cells, which are going through various stages of development to become sperm. So think of Sertoli cells as the nurse cells, and then the spermatogenic stem cells as undergoing proliferation to become sperm within the seminiferous tubules. And then located between the tubules are cells known as Leydig cells. And there's about 200 million in each testis. And they secrete androgens, primarily testosterone, but again, a little bit of androstenedione and DHEA as well. But we usually think of testosterone as the main secretion. There are also blood and lymphatic vessels located between the seminiferous tubules. There are different nerves and then fibroblasts that are part of the connective tissue there. So that's the general structure of a testis. A couple other things I'll mention is right here where all of the secretions, all the sperm that's generated in the seminiferous tubules collect. This area is known as the rete testis. And the rete testis will drain into a series of efferent ductules, which will all collect in what's called the head of the epididymis. And then from there, the sperm will travel up the epididymis and then up into the vas deferens. So that's the sort of flow of sperm from the testis. Now, there's two really important types of cells to know about in the testes, and that would be the Sertoli cells I mentioned. They're found in the seminiferous tubules. So if you look at a cross section of the tubule over here, you see the Sertoli cells are quite large. And then there are a bunch of these smaller cells. These are the spermatogonium, which are the stem cells of sperm. And then they're going to go and begin to proliferate to become sperm. And they're going to sort of move towards the lumen of the seminiferous tubule. And that's going to take a couple of months for that process to actually happen. But the seminiferous tubules are essentially supporting those cells. They're secreting different substances like estrogen. Look at that here in just a moment. And that's going to help with the sperm development. Very important thing also is that the Sertoli cells, although it's difficult to see here, are actually joined by tight junctions. So this is kind of difficult because we have to look at this three-dimensionally, but the Sertoli cells are really joined by tight junctions. And these tight junctions are constantly forming and reforming ahead and behind the different sperm as they're developing sperm as they're moving towards the lumen. And these tight junctions maintain what's called the blood-testis barrier. And this is very important because the sperm, as the spermatogonium develop, they start developing different gene combinations which are actually foreign to the male. And what we have here is outside the seminiferous tubules, there are blood vessels, and through that, immune cells come through, dendritic cells and so forth. And unfortunately, if these immune cells are directly exposed to the developing sperm, this can launch an immune reaction against the sperm, creating anti-sperm antibodies and so forth. This can happen, for example, if the blood-testis barrier is disrupted, trauma, surgery, things like that. We can actually start seeing anti-sperm antibodies being produced against the sperm, and that's going to usually make that man infertile or have less fertility. But normally the blood-testis barrier is going to prevent the immune system from actually being able to attack the sperm itself. So some have called the blood-testis barrier actually the Sertoli cell barrier because it's made up of those Sertoli cells. Other functions of the Sertoli cells, again, is to nourish the spermatocytes and the spermatids in the sperm. We'll talk about the different stages of sperm development. They all have different names. The Sertoli cells are going to help phagocytize damaged cells and any debris that's there. They're going to control the movement and release of sperm into the lumen. So they're going to actually help, again, form the tight junctions behind the developing sperm cells, and that'll help propel them forward and so forth. And then they're going to secrete fluid for sperm transport and secrete different hormones. One important one is Müllerian inhibiting substance. The Müllerian tract is what develops embryologically to give rise to the female reproductive system. The Müllerian inhibiting substance from the Sertoli cells will prevent or will cause that duct to regress, and that will allow for the development of the male reproductive system. This will also help facilitate the descent of the testes. The Sertoli cells also will secrete inhibins. I'll come back to that. That's actually going to feed back to the hypothalamus and anterior pituitary to cause a reduction of FSH. Remember, FSH, follicle stimulating hormone, is an anterior pituitary hormone, and there are FSH receptors on the Sertoli cells. And when FSH binds to the Sertoli cells, it will cause the Sertoli cells to make estrogens, primarily estradiol. And it's actually going to do that from testosterone, which is actually going to come from the Leydig cells I'll talk about here next. So the Leydig cells make testosterone, and then that is going to get aromatized via this enzyme aromatase, which is found in the Sertoli cells, into estradiol, 17-beta estradiol. And the estradiol will actually, as those levels rise, will actually inhibit FSH. And so that's a negative feedback to prevent too much estradiol from being made by the Sertoli cells. But the estradiol will actually help nourish the developing sperm. There is also a peptide called androgen binding protein in the Sertoli cells, and that's going to maintain a high local concentration of testosterone. And basically, most of that testosterone will be aromatized to estradiol, and that's going to help also that sperm development. So that's the Sertoli cells. Importantly, they have receptors here for FSH, and the FSH will stimulate, essentially, when it binds to the surface of the Sertoli cells, will stimulate the activity of aromatase, and that'll stimulate production of estradiol. So that's Sertoli cells. Between the seminiferous tubules, so outside of the tubule, and you see them here, are the Leydig cells. You can also see if these are the seminiferous tubules here. The Leydig cells are found outside. The Leydig cells, think of them primarily as secreting the androgens. And again, the biggest androgen is testosterone. In response to not FSH, but LH, luteinizing hormone from the anterior pituitary. So the pituitary essentially is regulating the testes. We're going to see the same thing in the female reproductive tract, where FSH and LH regulate the female reproductive hormones as well. The Leydig cells have receptors, again, for luteinizing hormone, which will increase the enzymes, and particularly cholesterol desmolase, which will be the first step in steroid enzyme synthesis. We'll review that pathway in the second video. The Leydig cells also have receptors for estradiol, so if the estrogen levels get too high, that will actually inhibit the Leydig cells, and that's kind of a feedback. So as the estradiol levels go up from the Sertoli cells, it'll feed back to limit the testosterone production, so we get less estradiol. Now, importantly, prolactin, again, another anterior pituitary hormone, at physiologic levels, will actually increase the number of luteinizing hormone receptors in the Leydig cells, and that will increase androgen secretion. Unfortunately, with high prolactin, and this is less common in males than females, but a prolactinoma, a pituitary adenoma secreting prolactin, creating essentially super physiologic levels of prolactin, will have the opposite effect. It'll actually inhibit FSH and LH, so that'll downregulate that, and that can actually lead to male infertility. So again, this is another interesting hormesis effect, where low levels have an optimal effect, and the higher levels of the same hormone in this instance can have an inhibitory effect. In the embryo and the fetus, there are Leydig cells that we call fetal type Leydig cells, and the production of androgen starts around week 8 to 20, maximum around week 15 of embryonic development. And these Leydig cells are not regulated by LH, but by HCG, human chorionic gonadotropin, which comes from the placenta. And they produce enough testosterone to actually cause masculinization of the male fetus. After that, though, after around week 20, the Leydig cells begin to regress and they remain inactive for the rest of gestation. And then they increase again in a couple months after birth. There's another testosterone surge. And then the cells go quiet after puberty. And that's probably to help brain development. Interestingly, in males, the testosterone which gets into the brain is aromatized to estradiol. And it's estradiol which causes male brain development. In females, curiously, there are proteins to bind up the estradiol. So in females, the brain development proceeds without the influence of estradiol. Kind of interesting, opposite of what you would think. At puberty, we start to see the adult Leydig cells come online, and the cells begin to increase after puberty. They reach a maximum around age 20, about 500 million cells, and then they remain steady between the age of 20 and 60 and begin to decline again. And this really matches the surge that we see in puberty of testosterone. Because they're making testosterone. And then the decline after 60 is when we really see testosterone diminishing, going into what's called andropause. All right, so that's a little on the physiology there of the Sertoli and the Leydig cells. Again, the primary stimulation for estradiol release from the Sertoli cells is FSH from the anterior pituitary, and the primary stimulator for androgen release from the Leydig cells would be LH from the anterior pituitary. So let me just say a few words here about spermatogenesis. This is the production of spermatozoa or sperm. There's about between 1 and 200 million sperm that are produced a day. I think the estimate is about 1,500 every minute. And it takes about 65 to 75 days to complete what's called a complete sperm cycle. So going from a stem cell to complete active sperm requires that a length of time. And again, semen is going to be composed of sperm, about 10%, and then the rest of it, 90%, will be seminal fluids that'll be secreted by the various accessory organs that the spermatozoa will go through. Just again, the technical name for an active sperm is a spermatozoa. Spermatogonia, this is the plural for spermatogonium, that's a singular. These are the sperm stem cells, and they're located, this is actually showing you a seminiferous tubule. So to actually complete the drawing, it'd have to be, of course, a big round structure like this. And this is the outer wall here. And then here are the Sertoli cells in gray. So that's the Sertoli cell. And lined up against the basal sort of membrane of the seminiferous tubule, there are the spermatogonium. And these are sperm stem cells. And they're there from birth. They develop in the embryo. And they're going to undergo development into a series of stages. First, the spermatogonia. I'll just say they are actually diploids, so they have the full complement of 46 chromosomes. We call that 2N chromosomes. And they're actually derived from the embryonic yolk sac, which begins, we start to see them first in around the 5th week of embryonic development. And they're going to serve essentially as a reservoir for sperm development, become very active at puberty under the influence of all the different hormones, especially testosterone and estrogens. They'll be active then. The spermatogonia will undergo mitosis, remember that's just cell division, and they're going to remain close to the basement membrane of the seminiferous tubule. Some of them will start to squeeze through tight junctions. So you kind of see that here with the Sertoli cells. This was a tight junction here that broke open, and now these spermatogonia are squeezing their way through. And they're going to start undergoing development. The first stage will be to develop into primary spermatocytes, and these cells are still diploid. They undergo meiosis 1, and after meiosis 1, they become haploid, and they undergo the second phase of meiosis 2, and become spermatids, which are haploid. So if you look at this picture, here is a spermatogonium with full 46 chromosomes, undergoes mitosis to become a primary spermatocyte, undergoes meiosis 1 to become haploid in the secondary spermatocytes, and then meiosis 2 to become spermatids. And so for a single spermatogonium, we're going to actually have to double this. So we're going to see 8 spermatids develop from that. And then the spermatids will undergo a process called spermiogenesis. This is assisted by the Sertoli cells to become spermatozoa or sperm. The spermatids actually look more, round. They have little tails developing, but really spermiogenesis is when they're going to lose a lot of their cytoplasm. And we'll look at the structure of sperm here in just a second. And they're going to develop little tails, and then we'll see the mature spermatozoa. Now, I'll just say the spermatozoa, when they're produced, are still not fully active. They're actually covered in a glycoprotein layer, and they're going to have to undergo a process known as capacitation. I'll talk about that here in a second. As they pass through the prostate, but then once they're actually ejaculated, and in the female reproductive tract, there are enzymes like heparin, which will actually assist the capacitation of the sperm to make them active. So that's the whole process of spermatogenesis. This is all happening again in the seminiferous tubules. Once they are secreted into the seminiferous tubules, they'll actually move their way into the epididymis. And in the epididymis, the sperm actually become motile. So their tails will start to wag. They can be stored in the epididymis and the vas deferens. And then they're transported into the penis via emission and then ejaculation out of the urethra. So we'll look at those processes coming up here. So that's the overview of the process of spermatogenesis. So the estimates are, we see different numbers here in different texts. So anywhere between 100 and 300 million sperm per day complete the process of spermatogenesis. Now, once ejaculated, though, again, they can be stored at different parts of the duct system, like the epididymis and the vas deferens. But once they're ejaculated, most sperm don't survive more than 48 hours within the female reproductive tract. So that's going to narrow the fertility window pretty shortly. If we look at sperm, they are very interesting compared. If you look at a sperm and an egg together, egg cells are huge. In fact, it's one of the few cells in the body we can actually just barely see with the naked eye without a microscope. They have a nucleus that's kind of compressed up against the edge. And if we look at the egg cell, it is packed full of cytoplasm. And there are mitochondria in there, of course. And again, we actually get all of our mitochondria from the egg. So the mitochondria and so forth. So that's an egg cell. We can think of that as very cytoplasmic. If you look at a sperm, it actually is quite small compared to the egg. And it has a very compact head. And the head itself has a nucleus and has very little cytoplasm. So the head is mostly just nuclear material. And then it has this acrosome on the outside. The acrosome is a layer of enzymes, and that's going to be very important. That has to be activated before it can actually begin to enter into the ovum, the egg. And then there is a area of kind of a neck, a connecting piece, which is rich in mitochondria. And then there's a tail made of centrioles, and then there's a little end piece on the tail. So again, the head itself, very small, it's kind of flattened. It has a pointed structure to it. It has 23 chromosomes, of course, it's haploid, just like the ovum. And the acrosome is going to cover about 2/3 of the nucleus, and that's going to contain, again, enzymes that will help with fertilization. The tail has 4 parts there. There's the neck, as I mentioned, right here. There's the middle piece, principal piece, and then the end piece. The neck has centrioles, and these form the microtubules. They're going to lay down the proteins for the microtubules of the tail. The middle piece contains lots of mitochondria, and that's going to provide ATP for the tail. And the principal piece, this is the longest portion of the tail, formed of microtubules. And then there's a tapering terminal portion again. So that's the basic structure of sperm. Now, a lot of important things clinically. Many of our patients may be coming to us to discuss infertility, and we'll get into male and female infertility. Just rough estimates are with couples that are infertile, about half of the cases are due to male infertility, about half to female infertility. So one of the things we have to always look at in the male infertility is the factors that help sperm develop. So we know that, of course, maintaining proper testicular homeostasis is going to be important for sperm development. So the proper temperature, if there's any ischemia, for example, if there's any torsion, testicular torsion, I'll talk about that here coming up. If there's any problem with the spermatic cord not delivering enough arterial supply to the testes, that can lead to decreased sperm production. Inflammation, classic example of that is from mumps. Mumps causes an inflammation of the testes called orchitis or mumps orchitis. And so that would lead to potential infertility. And then testicular size, depending on, these could be genetic factors and things like that, which will affect the testicular homeostasis. But very importantly, and this is what we can modify clinically, would be the endocrine factors that affect sperm development in the testes. So one of them is melatonin. Melatonin, we know at physiologic levels, actually is generally protective to sperm. However, at superphysiologic levels, and this happens before puberty, your pineal gland releases, remember, lots of melatonin before puberty, and this suppresses sex hormone development. It'll suppress sperm development in the case of a male. So this will decrease sperm counts. And this is something to consider when giving patients melatonin supplements. Again, physiologic levels of melatonin we think would be potentially achieved by taking supplements around 0.5 milligram to 1 milligram of melatonin. We start getting up to 3 milligrams or higher. Now we're getting into what we might call super physiologic doses, and that could potentially suppress sperm production. So just think about that. If you have working with a male patient who has insomnia, maybe he's taking high dose melatonin, that might be something to discontinue or to change the dosage. Hypothalamic pituitary factors will be important. Again, FSH stimulates the Sertoli cells and LH the Leydig cells to produce testosterone. We know that high stress hormones, high ACTH, will generally suppress FSH and LH, and that usually leads to low sperm counts. So that's another thing to look at, is maybe HPA axis overactivation, increased stressors and things like that. Thyroid, we know, is very important for not just sperm production, but also for ejaculation. In fact, erectile dysfunction and so forth, we find in hyperthyroidism, men tend to suffer from premature ejaculation. Hypothyroidism would be the opposite. But generally, low thyroid leads to low sperm counts. And then we think adrenal DHEA may be protective to sperm and may increase the sperm counts. I put the question mark there because that's more of a hypothesis. We do know that different toxins, chemical carcinogens, different pharmaceutical medications, the list is very long, you can look that up. Environmental toxins and pesticides, irradiation, and then importantly, oxidative stress, increased oxidative stress in the body. All of this can affect sperm development. One of the really important factors we're finding is that a lot of these environmental, especially lipid-soluble toxins, are xenoestrogens. They have an estrogenic function. So they're going to tend to increase estrogenic activity, but not the androgenic activity, which ultimately would have a role of decreasing sperm activity. There's been hypotheses that different micronutrients, different antioxidants could be protective to sperm, and here's one clinical study from 2011 that actually found an improvement of sperm quality after micronutrient supplementation. So your classic things like selenium, zinc, vitamin E, CoQ10, and so forth would be on that list. And then many other vitamins you'll see in the literature, or at least anecdotally people are using for infertility. The problem with all of this is we're beginning to see more and more that although many of these nutrients are protective, they're best obtained through the diet, not through supplements. And so we're seeing a lot of negative results come out with supplement studies with a lot of things. And I think some of the newer studies on infertility have not been able to reproduce the same effects with a lot of these so-called antioxidant supplements. And again, by hormesis, taking too much of an antioxidant supplement could potentially have a negative impact by downregulating reactive oxygen species, which we know in cells is actually a cell signaling molecule, which helps to upregulate cell protective mechanisms. So if you turn that off with too much antioxidant, you're not going to get the same beneficial effects in the cells. But getting the right amount from the diet seems to be optimal. So more and more we're seeing that getting calcium, getting all these different nutrients, antioxidants from the diet, and herbal therapies and so forth is far better than taking these in concentrated form in a vitamin or multivitamin pill. So just bear that in mind. So I mentioned a little bit about the role of the hypothalamus and the pituitary in regulating the testes. I just want to kind of go through that again so you're very familiar with what's going on here. And this refers to what we call the HPG, hypothalamic pituitary gonad, or in the case of a male, HPT, hypothalamic pituitary testes axis. And this begins up in the hypothalamus with the release of GnRH. These neurons actually migrate, that secrete GnRH, migrate from the olfactory bulb. And so I'll talk about a congenital condition where those neurons don't properly migrate, and we'll get a problem in the whole HPT axis. But basically GnRH, gonadotropin releasing hormone from the hypothalamus, is going to stimulate in the anterior pituitary gonadotrophs to release FSH and LH. And there is a circadian rhythm to both of these. Now, in females, the FSH is primarily released during the follicular, the first 2 weeks of the menstrual cycle. And then LH is going to be released primarily in the last half of the menstrual cycle between ovulation and menses. And males, they seem to be released together at the same time. So both FSH and LH are released. LH is usually highest in the morning hours, and that correlates with the morning surge of testosterone. The FSH is going to travel in the blood to the testes, and it's going to primarily bind to FSH receptors in the Sertoli cells. And again, that's going to stimulate spermatogenesis. And specifically, it's going to stimulate the aromatization of testosterone to estradiol, which will help with that. It's going to increase the levels of androgen binding protein, which again keeps more testosterone around that can be aromatized to estradiol. It's going to also help to, both the estrogen and the testosterone will help then to stimulate the final steps of spermatogenesis. Now, once the Sertoli cells secrete enough estradiol, that's going to, and testosterone, for the purposes of spermatogenesis, the Sertoli cells will secrete inhibin, and the inhibin will travel back in the blood to the pituitary gland. So you can see that here. Here's a Sertoli cell. Here's the FSH stimulating. Inhibin's going to feed back to the pituitary and inhibit further FSH release. So that's kind of a negative feedback mechanism to prevent too much FSH from being made. LH is going to enter the blood, and it's going to stimulate the Leydig cells to release testosterone. It's going to stimulate the steps of testosterone synthesis in the Leydig cells, and I'll go over that in the second video. Testosterone will then diffuse into the blood, and it will exert a negative feedback on the hypothalamus to cause the release of GnRH, to inhibit, the release of GnRH. So we get less of that, and that turns down the LH secretion. So that's a negative feedback. So too much testosterone is not made. Now, importantly with testosterone, this is a steroid hormone, so this is going to require a binding protein to be carried in the blood, and that is known as sex hormone binding globulin, SHBG. That's synthesized in the liver, and that's going to form bound testosterone. Remember that we also need free testosterone, so testosterone has to come off of that carrier protein in the peripheral tissues, and then it can diffuse into those tissues to become active. So our total testosterone is the combination of our free testosterone, which is very small, about 2%, with the bound testosterone. And it's the free testosterone which will be able to bind to androgen receptors, which we'll go over that in the second video, which are found really all throughout the body. And this is going to exert both genomic effects. It's going to bind to an intracellular steroid receptor, which will cause increased gene transcription and translation into different anabolic proteins. And it will also stimulate non-genomic effects. There is a membrane-bound androgen receptor, and that tends to stimulate more enzyme pathways within the cytoplasm. And so this is what we mean by genomic and non-genomic actions, and we'll go over that later. Now, one important point I want to make is that in males, testosterone also works through two different metabolites to exert sort of the effects of testosterone throughout the body. One of them is through a more active form of testosterone known as dihydrotestosterone. And DHT is synthesized from testosterone via an enzyme 5-alpha reductase. So testosterone to dihydrotestosterone, again, the enzyme here is 5-alpha reductase. And 5-alpha reductase is found in the skin, hair follicles, and the reproductive organs like the prostate. And DHT has a more, 10 to 20 times more action than testosterone itself in those tissues. So lots of dihydrotestosterone will tend to cause more acne in the hair follicles, will tend to cause more hair loss, more acne in the sebaceous glands. In the skin, more hair loss in the hair follicles when it's overstimulated. And we think it can also drive the growth of prostate gland tissue in forming what's called benign prostatic hyperplasia in older men. We'll come back to that in the pathology section. So that's another way that testosterone can work is via DHT. And then many tissues, especially adipose tissue, contain aromatase. So I mentioned aromatase in the Sertoli cells. It's also found throughout the body in males, and the levels of aromatase actually go up with age in men, and especially if there's a lot of adipose tissue. And what happens there is the testosterone is converted to estradiol. Should also mention that androstenedione, so another pathway here is estradiol, E2, and that's via aromatase. Another pathway is that androstenedione, another androgen, is aromatized to estrone, E1. And this is a particularly negative estrogen. We'll come back to that in detail in the female reproductive section. This is primarily the estrogen that women make after menopause, and we think it has more potentially cancer-forming effects, especially the different metabolites of estrone. But aromatase is able to convert both of those androgens into estrogens. But this is another way that testosterone can work is via estradiol. So curiously, we usually think of just testosterone effects, but it can actually work by its conversion into estrogens as well. One final point here, I mentioned that those GnRH neurons don't properly migrate in some cases from the olfactory bulbs in fetal and embryonic development, and this is known as Kallmann syndrome. And this can result in hypogonadism because there's no GnRH, so no FSH, no LH, no development of the Sertoli or the Leydig cells. And interestingly, another clinical correlate with that is that people often have anosmia. They can't smell. So I've actually had that where I've had patients presenting with premature sort of failure of the gonads, and the reason we detect clinically is they're not secreting those gonadotropins, and they actually have a clinical sign of anosmia, and we usually look a little bit more into that, and we diagnose them with Kallmann syndrome. So not common, but I've actually seen a couple of patients with that, which is why I actually put it on the list here. Okay, so that is an overview of how the testes are regulated by the hypothalamus and the pituitary, the anterior pituitary, the so-called HPT axis. Now, once sperm are produced in the seminiferous tubules, we're going to look at what happens to them, where they go from there, and that is where we bring up the discussion of the duct system. So the Sertoli cells are actually creating a fluid, and that's creating a gentle pressure, which is actually going to push the sperm along the seminiferous tubules, and they're going to actually go through a series of straight tubules within the testes and collect in what I pointed out earlier is the rete testes. And the rete testes is sort of, if we look at the testis here on the picture on the right, I'll draw it in blue. The retestes is right here. So all these different ducts converge into that. And then that's going to drain via a series of little ducts into the epididymis. So these are called efferent ducts, and that'll go in the epididymis, and then that's going to, the sperm from there will go into the vas deferens or ductus deferens, and then into the ejaculatory ducts, which are here in the prostate, and then they'll enter the prostatic urethra and then go out the urethra. So let's look at the epididymis here first. The epididymis is about 20 feet in length if you were to fully unravel it. It lies on the posterior border of the testes, and this is essentially, again, a series of tightly coiled tubes. And the efferent ducts from the testes will all join this area of the epididymis called the head of the epididymis, which is the upper portion here. The sperm will then travel into the body of the epididymis and then flow into the vas deferens via the tail of the epididymis. Essentially what happens there is that sperm will be stored, they'll be protected, and then the maturation will begin. So this is where the sperm will start to become motile. So they'll start to have activity in their tails. The epididymis itself, it consists of, the mucosa consists of pseudostratified columnar epithelium with microvilli. So the microvilli actually help propel the sperm through the epididymis. There's also smooth muscle in the epididymis, and this will be part of the process whereby sperm is actually pushed through the epididymis and the vas deferens into the urethra. That's the first part of ejaculation called emission. So the emission of sperm through the epididymis is assisted by the smooth muscle in the epididymis, and that's going to be activated during sexual arousal. Again, this is where sperm are maturing, becoming motile. That takes about 2 weeks though. So once the sperm are produced in the seminiferous tubules, it takes about 2 weeks for them to kind of mature in the epididymis. And the sperm can be actually stored here for several months. Any sperm that is not ejaculated will just be reabsorbed. So it's not like it sits there and decays or anything like that. It just is reabsorbed. All the nutrients are reabsorbed, and the amino acids are reabsorbed. If a male has frequent ejaculations, this will decrease the total number of motile sperm, and that can actually affect fertility in some cases. From the epididymis, the sperm will then travel to the vas deferens, which is only about 18 inches long. It's wider, and the vas deferens will actually loop around again the ureters. So you see that in the picture here, loops around the ureters behind the bladder, and they're going to converge and enter the prostate gland. The vas deferens is going to ascend along the spermatic cord, which I'll talk about here shortly, and that's going to enter the pelvic cavity, again, go up over the ureters of the bladder, and then pass behind the bladder, and then they're going to converge in an area called the ampulla. This is a dilated terminal portion, and that's going to join the urethra inside the prostate. The vas deferens mucosa is made up of pseudostratified columnar epithelium, and there's 3 layers of smooth muscle, and that's what's going to actually help with the emission of sperm once that's activated. I'll just say the emission of sperm is primarily under sympathetic regulation, versus erection is actually under parasympathetic regulation. We'll come back to that here in just a moment. So the sperm can be conveyed via peristaltic movements of that smooth muscle during arousal. The vas deferens can also store and resorb sperm, and that's important because there's a procedure you're most likely familiar with called the vasectomy. That's a cutting and ligation of the vas deferens, so usually down here just after they pass through the epididymis. It's a very simple outpatient procedure, and this is really a form of permanent male contraception. The important thing, though, is that sperm can be stored in the ampulla, this region here where it joins in the prostate, for up to 4 to 5 weeks after a vasectomy. So a man theoretically could be fertile for up to that time. Okay, so that's the vas deferens. And then the ejaculatory ducts, each is about 1 inch long. And these are formed here inside the prostate. And that's really the end of each vas deferens. And this is where the seminal vesicles, which we'll talk about here shortly, join up as well. And they're going to secrete their secretions into the ampulla. And this is going to then enter into the prostatic portion of the urethra. So that's the ejaculatory ducts, and the urethra itself is about 8 inches long. That's going to pass through the prostate, through the peritoneal muscles and the pelvic floor, and go through the penis and then exit. And of course, that's also going to pass urine from the bladder as well. So that is the entire ejaculatory duct system. One final very important structure we need to know about is the spermatic cord. And this is really the supporting structure of the whole male reproductive system. It runs from the deep inguinal ring down to each testicle. And it's formed essentially from the vas deferens, from a layer of tunica vaginalis. Again, that's the serosa that's surrounding the testes, but it also covers the spermatic cord. And it's derived from the abdominal peritoneum embryologically. Within the spermatic cord is also the cremaster muscle and fascia, and that's a continuation of the internal abdominal internal oblique muscle. There is a testicular artery and cremasteric artery, so 2 arteries, and then there are veins, and we already looked at the pampiniform plexus, and that's the venous drainage from the testes, which will carry testosterone into the body. The right testicular vein actually drains into the inferior vena cava directly, versus the left testicular vein, interestingly, drains all the way up into the left renal vein. And that's because embryologically, again, the testes essentially come from the kidney region, they descend down, so they're going to carry all those structures with them. There are lymphatic vessels in the spermatic cord, and then different nerves. In particular, the genital branch of the genital femoral nerve. This comes from your lumbar plexus, part of your somatic nervous system, and that's going to innervate the cremaster muscle. And there are testicular nerves that are sympathetic from the hypoglossal plexus up around, coming from T10 to L2 in that region. The contents of the spermatic cord are all bound together by 3 fascial layers. Again, these are all derived from components of the anterior abdominal wall. So the external spermatic fascia, the cremaster muscle and fascia, and the internal spermatic fascia. Those are kind of technical things, but think of this really as a supporting cord reaching down from the abdominal cavity, carrying the arteries, the veins, the nerves, lymphatics, and all these different fascial layers. The spermatic cord and the ilioinguinal nerve, which is another nerve from the lumbar plexus, part of your somatic nervous system, passes through the inguinal canal, and that's again an oblique passageway in the anterior abdominal wall. So you kind of see it descending through these different layers here. There's an important reflex known as the cremasteric reflex. This is one we typically don't test unless we are suspecting a problem in the genital region. But basically, this is a superficial reflex that's elicited when the inner part of the thigh is stroked. This stimulates the ilioinguinal nerve, and this causes the cremaster to contract, and the testis on that side will raise. And so we'll see this is important because in cases like testicular torsion, which I'll talk about here shortly, the cremasteric reflex usually is absent. So that's the cremasteric reflex. The inguinal canal itself is about 2 inches long. Essentially, think of it as a passageway through all these different layers of muscle and fascia for all these different structures like the spermatic cord to pass through. Its origin is in the deep inguinal ring, which is just underneath the peritoneum in the abdominal cavity. And then the end is the superficial or subcutaneous inguinal ring, and that is down here. So the inguinal canal, which contains, again, the spermatic cord and the ilioinguinal nerve, are going to pass through the structure here. In females, the round ligament of the uterus and the ilioinguinal nerve as well pass through the canal. But of course, it's not going to protrude through the abdominal canal. It's going to be carried within the abdominal cavity. Importantly, there are 2 types of inguinal hernia. So the most common type is what's called an indirect inguinal hernia, and that's failure of closure of this deep inguinal ring. So this doesn't close, and essentially this allows the intestine to actually protrude down through the inguinal canal. And the loop of an intestine can actually go down into the scrotal cavity. And the danger of that is it can become incarcerated, where it becomes twisted. It blocks the blood flow to that portion of intestine, and that can go gangrenous. So that's an acute complication of the indirect inguinal hernia. There's another type of hernia called a direct hernia, which involves sort of a weakness in the abdominal wall, and the intestine can protrude through that, but not through the deep inguinal ring. So it passes through the superficial ring, but not the deep ring. One important medical emergency is testicular torsion. Fairly common, so you should be aware of it. This is considered a medical emergency. And what happens here is the spermatic cord actually twists upon itself, and that can lead to strangulation of the testicular artery, causing ischemia and a potential infarction of the testis that's supplied by that artery. And that can cause necrosis of the testes within just a few hours. Usually this results in or presents with severe and sudden pain in the affected testis. And you see that affected testes will be elevated into the scrotum, and there will be no cremasteric reflex. And usually this is caused by a spasm of the cremaster muscle itself. So the assessment is done usually via Doppler ultrasound, and then different techniques. Orchiotomy is where we actually remove the affected testis. And an orchiopexy is used to try to resolve the torsion. I should say that's also surgery used to help, in the case of undescended testes, to help the testis descend. So that's testicular torsion. That's an important condition you should know about. I'm going to go over most of the conditions of the scrotum and the different reproductive male organs here in the pathology section, but this is one I'll just point out here. Now, as the sperm passes through the duct system, there are various accessory organs which essentially add their secretions to create the seminal fluid, and that'll help create semen. So the first structures to know about are the seminal vesicles, which are located right behind the bladder here. And they secrete an alkaline viscous fluid that contains fructose, vitamin C, prostaglandins, different antioxidants, as well as clotting proteins. And this will actually cause the semen to coagulate. It's not quite understand why that happens, but that's something that's going to stimulate coagulation. Now we're going to see other secretions will act as anticoagulants to prevent that from happening. The seminal vesicles secrete up to 60% of the volume of the semen. So that's the first. And you can see in this picture down here how these come together. There's one seminal vesicle that's going to drain into each of the endings of the vas deferens as it comes through here. And then as they join, they're going to form the little ejaculatory ducts, and that will then converge into the urethra. And this is the prostate here. So this is going to all converge into the prostatic urethra to go down into the penile urethra. The prostate gland is the second accessory organ here. It's an exocrine gland. It's made up of both glandular tissue and then fibromuscular tissue, mostly smooth muscle, and then there's stromal tissue as well. It's about the size of a golf ball. It's inferior to the bladder, and it surrounds, again, the prostatic urethra. It slowly increases in size from birth to puberty, and then it rapidly grows again until about the age of 30, remains stable, but in many men it begins to grow again after the age of 45, and that leads to hyperplasia. Remember, hyperplasia is an increase in the number of cells in a tissue, and that leads to a condition called BPH, benign prostatic hyperplasia. The prostate is surrounded by a fibromuscular band called the capsule. And that'll be important because prostate cancers that develop in the prostate, there's different stages of the cancers. There are the less aggressive and the more treatable cancers are still found within the capsule. Once they are found outside the capsule, the prognosis for those cancers goes down considerably. The prostate itself, where the urethra comes out, is actually going to be sheathed in the muscle of the pelvic floor also. Now, importantly, within the prostate and within the smooth muscle that surrounds the urethra, there are alpha-1 receptors for norepinephrine. So sympathetic nerves will come in here, and if those nerves are firing and releasing norepinephrine, this will cause urinary retention. And this is important because a very important class of medications used for BPH to improve urination. So what happens in BPH is in this region called the transition zone. So that's here. This starts to grow and it's going to compress the urethra. So in BPH, the urethra becomes compressed and it makes urinating very difficult. One of the major classes of medications to treat this are alpha-1 blockers. They're medications that block the alpha receptors and they try to relax the smooth muscle around the urethra to try to increase urinary outflow. So alpha-1 antagonists are a very important class of medication for BPH, and we'll look at that more in the pathology section. Um, Again, the BPH tends to grow in the transition zone. There are three other zones in the prostate. There is a peripheral zone, which is depicted here in green, and that kind of wraps around the outer edges of the prostate, and that's primarily where prostate cancers tend to grow. So importantly, BPH and prostate cancers tend to grow in different parts of the prostate, and again, we'll come back to that in detail in the pathology section. The prostate itself secretes a milky alkaline fluid, which is going to aid sperm mobility and viability, and it contributes about 20%. So again, seminal vesicles 60%, prostate about 20%. And the prostatic secretion is usually expelled in the first part of the ejaculate. And it's going to contain several things. One is citric acid, making it acidic. And this is going to be important for ATP production in the sperm. So sperm can use that as an energy source. There'll be proteolytic enzymes in that fluid, including prostate-specific antigen, PSA. So PSA we also use as a blood marker. Whenever there is growth of the prostate, like in BPH or prostate cancer, but also injury to the prostate, etc., you'll find more PSA in the blood. And so that has been historically used as a marker for prostate health. A lot of controversy about PSA testing. Again, we'll come back to that in the pathology section. It's so nonspecific that it's really hard to use PSA alone to differentiate cancer from other injury to the prostate. And unfortunately, using PSA thresholds has resulted in a lot of overtreatment and overdiagnosis of prostate cancers, and given men a lot of unnecessary medical treatments as a result of that. But the PSA is one example of a proteolytic enzyme in the prostatic secretion. There's also pepsinogen, lysozyme, amylase, hyaluronidase. All these are going to help break down, for example, clotting proteins from the seminal vesicles. I mentioned that the seminal vesicles add coagulation proteins to the semen. The prostate helps to neutralize that. There's also acid phosphatase. We're not quite sure what that does. And then there's an antibiotic that's secreted by the prostate fluid called seminal plasmin, which is going to prevent any potential bacterial growth in the seminal fluid. And then finally, there are the bulbourethral or Cowper glands, which are found here just underneath the prostate, right here. And they're going to add their secretions just into the urethra. And they're paired. They're about the size of a pea. And they're, again, located deep underneath the prostate in the peritoneal muscles themselves. The ducts will actually open into what's called the spongy urethra, which is found inside the penis, and they secrete an alkaline fluid, which is going to neutralize the acidic fluid from the prostate, and that will be released during sexual arousal. And again, that's going to help protect sperm. They also secrete mucus, and that's going to lubricate the passage for the sperm. Sometimes before actual ejaculation, the little excretion that comes out, that's thought to be primarily from the bulbourethral glands, and there's about 1 or 2 drops of that. There's no sperm that are contained within those secretions. All right, so that's the 3 primary accessory organs which are going to help produce the seminal fluid. Now, semen is a mixture of sperm and seminal fluid. The seminal fluid, again, is created by the secretions really from the Sertoli cells in the seminiferous tubules, the seminal vesicles, prostate, and the bulbourethral glands. The prostatic secretions will give the semen a milky appearance. The seminal vesicles and the bulbourethral glands will give it more of a sticky consistency. And then there's an amino acid or a protein called spermine, which gives the odor to sperm. And then in general, we can think of this seminal fluid as actually protecting the sperm in the male urethra. It'll also help protect the sperm in the female vagina from the enzymes and the different environmental factors there. On average, for an average ejaculate, the volume is about 2.5 to 5 milliliters, and with each ejaculate, up to 200 million sperm per milliliter are found. By definition, infertility is when we get under 20 million sperm per milliliter, and especially under 15 million sperm per milliliter. That's absolute infertility. The ejaculate is slightly alkaline, so pH just over 7. And once it's ejaculated, it coagulates within just a few minutes, and that's due to those clotting proteins from the seminal vesicles I mentioned in the last slide. We're not quite sure what that function is for. After about 10 to 20 minutes, though, again, the semen will then liquefy due to the proteolytic enzymes from the prostate. And we know that abnormal or delayed liquefaction of the clotted semen can actually lead to immobilization of the sperm, and that's going to inhibit the sperm movement to the uterine cervix. So the prostate has a very important role at preventing that overcoagulation. After passing into the uterus and the uterine tube, the uterine secretions, especially heparin, will, I mentioned that when sperm are produced, they have this glycoprotein sheathing around them that needs to be removed before they can actually enter the ovum. And that process of removing that glycoprotein layer is called capacitation. The prostate secretes a couple of enzymes that helps with that, but it's primarily heparin and other enzymes in the uterus which stimulate capacitation of the sperm. Now, one condition you might encounter clinically is hemospermia. That's the presence of blood in the semen. And it's most common in fairly younger males, 30 to 40 years of age. It's usually caused by inflammation or infection of the blood vessels lining the seminal vesicles. It's most commonly a benign symptom, so this is not considered a medical emergency or anything like that. It, however, should be investigated. It could be an indication either of prostate cancer. It's usually idiopathic, but it could also indicate an STI, like gonorrhea or chlamydia, or maybe even E. coli. And so in those cases, we might think about treating with antibiotics. So that is hemospermia. Now, semen analysis is going to be a very important workup for infertility and for male health in general. This requires ideally at least 3 semen samples that should be examined over a 2 to 3 month interval. And importantly, a couple of steps if you're going to order a semen analysis, your patients need to have abstained from sex for ideally a week, but it can be as little as 2 days. And we need to examine the semen microscopically within an hour of collection. So you have to send someone to a center where they can do that. The sperm count decreases with repeated ejaculation, which is why we try to have the abstinence. Normal, again, semen volume is between 2 to 5 milliliters per ejaculation, and the pH should be just over 7.4. We should have between 60 and 70% of active motility and about 50 to 200 million sperm per milliliter. And about at least 30% of the sperm should have normal morphology. So those are all measurements that are used in assessing male fertility. The WHO definitions of infertility usually is a semen volume under 1.5 milliliters, or a sperm concentration less than 15 million sperm per milliliter, progressive motility less than 32%, total motility less than 40%, only 58% or so are live, and then morphology, only 4% have normal form. So those are some of the definitions that are used if you see a report. If you send a male for a semen analysis, you might see some of those parameters being given. A couple of important terms to understand for semen variables. Aspermia means no semen. Azoospermia means no spermatozoa in the ejaculate. Asthenozoospermia is the percentage of progressively motile sperm is less than 32%. Normal zoospermia means you have normal ejaculates with normal parameters indicating fertility. Oligoasthenoteratozoospermia is big name, just remember oligo small, astheno less activity, and then terato is deformed or abnormal morphology. So this is a sperm concentration and percentage of progressively motile sperm and morphologically normal sperm below the lower reference range. And then oligozoospermia would be sperm concentration lower than 15 million per milliliter, and teratozoospermia would be percentage of morphologically normal sperm less than 4%. So lots of little terms, but good to have some familiarity with them, especially if you ever send a male for a semen analysis. So once the sperm have traveled down the urethra, gone through the prostate, have had all of the accessory organs add their secretions to it, it's going to enter, of course, the penile urethra. This is, again, the same urethra that's shared with the bladder, so to allow for the passage of urine. The penis itself consists of a body or a shaft. The head of the penis is called the glans penis, and the root is what anchors the penis to the peritoneum. So it's also known as the base of the penis. So base, shaft, and glans. And sometimes there's a foreskin, if that hasn't been removed surgically, over the glans penis itself. If we look inside the body or the shaft of the penis, there are 3 cylindrical masses of spongy tissue. Each mass is surrounded by a fibrous coating called the tunica albuginea. And the 2 dorsolateral masses are known as the corpora cavernosa. So you can see them in this picture over here. And then there is a spongy tissue surrounding the urethra called the corpus spongiosum. And the spongiosum is going to be important for keeping the urethra open during erection. So that's the main role of that. But the corpora cavernosa will be important for actually maintaining erection. And we'll talk about that process here in just a moment. These masses are essentially surrounded by erectile tissue that are composed of numerous vascular spaces with blood sinuses, and the spaces themselves are lined by endothelial cells. Remember, that's the vascular epithelium. And they are surrounded by smooth muscle and elastic connective tissue. So during an erection, what's going to happen essentially is that the arterial smooth muscle is going to relax, and the blood's going to flow into the penis. And then the venous smooth muscle, but also the vein. Remember, veins have very little smooth muscle, and they're easily collapsible. As the penis, the spongy tissue dilates with blood because the arterial smooth muscle has relaxed. It's going to collapse the veins, preventing blood from leaving the penis, and that's going to cause the erection. And the main activator, the main trigger for relaxing the arterial smooth muscle is the production of nitric oxide, and that's going to be stimulated by parasympathetic nerves from the pelvic plexus. They're going to trigger the release of nitric oxide, and they are going to, both from the nerves are going to release it, endothelial cells will also release it secondarily, and that's going to diffuse into the smooth muscle around the arterioles, and that's going to activate cyclic GMP. And the cyclic GMP will then work to relax the arterial smooth muscle, and that's going to allow for the blood to enter into the penis. Importantly, and I'll talk about these more in the next slide here, there's a class of medications. So these are known as the PDE5 inhibitors. So PDE5 is an enzyme that's going to inactivate cyclic GMP. So by inhibiting PDE5, you're going to keep more cyclic GMP around, have more vasodilation of those arterioles. And these are the classic drugs that are used for erectile dysfunction, like Viagra, sildenafil, tadalafil, which is Cialis, and vardenafil, which is Levitra. Those are the 3 primary drugs used with erectile dysfunction. Again, by affecting nitric oxide and cyclic GMP around the body and vascular smooth muscle, this actually can have a pretty profound effect at decreasing blood pressure. So curiously, these were originally developed as blood pressure medications, but they found that the blood pressure lowering effects were actually a little too intense and not, it was very difficult to regulate. But they found that a number of these men, when they were doing trials on the medications, had sustained erections. And so they remarketed it as drugs for erectile dysfunction. And this is why, of course, we have to be very careful about these medications with males who are on antihypertensive medication, because that can cause a very profound drop in their blood pressure. So that's the body of the shaft with the spongy tissue, important for erection. The distal end of the corpus spongiosum, remember that's the spongy tissue around the urethra, that forms the glans of the penis. That's the head of the penis. The corona is the margin of the glans with the shaft, so that's this region here. And the glans is very sensitive, contains a lot of nerve endings, and this is what is activated in sexual arousal. The external urethral orifice also opens up through the glans, and that's where, of course, the urethra exits. There is a covering of skin called the prepuce or the foreskin, which is normally there covering the glans. That is removed for a variety of reasons. If you remove the prepuce, you expose actually squamous mucosa, and that will over time actually just transform into normal skin. That is thought to allow for greater sensitivity. The head of the penis, it's done for a variety of social, cultural, religious, and sometimes, but rarely, medical reasons. We think it might decrease the risk by removing the foreskin of urinary tract infections, might reduce the transmission of sexually transmitted diseases, and potentially reduce the risk of penile cancer, squamous cell cancer. Most of that's pretty, we don't think medically that actually that has a tremendous role. So mostly circumcision is done for these other reasons. All right, so that's the overview of the penis and the relevant structures there. Finally, I just want to say a few comments about erection and ejaculation. So erection itself is stimulated by parasympathetic nerves, so sacral parasympathetic nerves. They are the ones that release nitric oxide, and that's going to activate the cyclic GMP in the smooth muscle around the blood vessels. And that's what's going to cause the penile arterial smooth muscle relaxation. That'll cause the corpora cavernosa to swell. That'll compress the veins and restrict the blood from exiting the penis. And this will cause the rigidity and enlargement of the penis. And then once the nerves stop firing and nitric oxide process stops, that process reverses. Now, erectile dysfunction, also known as impotence, is really defined as the related inability to get and to maintain an erection adequate for sexual intercourse. It can be physiologic or psychological. In terms of physiologic causes, the most important would be cardiovascular disease. So remember, in cardiovascular disease, we have generalized endothelial dysfunction, and that includes the endothelium in the penile arterioles. And so that causes them to produce less nitric oxide, and there's less dilation of the smooth muscle, and so there's going to be less blood flow into the penis. In fact, some sources kind of argue that one of the first signs of systemic endothelial dysfunction is erectile dysfunction. So ED is not something that's just local to the penis. It really could be related to metabolic imbalances, such as insulin resistance and so forth. Traditional medicines like Chinese medicine call this blood stasis. Endothelial dysfunction and blood stasis really go together. There could be neurological problems with trauma to the penile nerves. There could be hormone insufficiencies, in particular low testosterone, but we also know that low thyroid, potentially high insulin, inadequate melatonin, all of these can also impact the penile environment, homeostasis, and then different drugs can obviously affect endothelial dysfunction. So clinically, when patients present with ED, we want to kind of go through this. Okay, is it likely that there's a psychological reason to this? If not, let's go through our list of physiologic causes. I mentioned the PDE5, phosphodiesterase type 5 inhibitors that inhibit the breakdown of cyclic GMP via PDE5, and that's going to cause vasodilation of the penile arteries, and these are used for erectile dysfunction as some of the main biomedical treatments. From a more naturopathic angle, or Chinese medicine angle, we can think of doing things to protect the endothelial health, to reduce blood stasis and so forth. So a lot of our cardiovascular herbs in the West, for example, crataegus and so forth, could be thought about as maybe part of the treatment plan there. Priapism, I just want to say a word about that. That is a persistent and unusually painful erection that doesn't involve sexual desire or excitement, can last up to several hours or longer. And the danger here is that blood is pooling in the penis. You're not getting proper oxygenation of those tissues. And so this is considered to be, after 4 or 5 hours, a medical emergency that needs to be treated. And there's a lot of different causes for it. It can be medications, could be spinal cord injuries, leukemia, sickle cell crisis, tumors, etc. Generally, what has to be done in the ED is they have to actually remove the blood from the spongy tissue, usually by draining it out via needle. So that's not a very comfortable procedure, but that there's different medications that can help with that as well. But that needs to be, after a few hours, needs to be addressed. So that's erection. The actual ejaculation of semen really involves two different stages. One is emission, and the other is the actual ejaculation out of the urethra. The emission is really where the sperm and the spermatic fluid pass from the epididymis and the vas deferens into the urethra. So it's the process that gets the fluid moving and the semen moving from the epididymis and the vas deferens into the urethra. And it's mediated by sympathetic nerves, which originate around L1, L2, part of the hypogastric plexus. And this causes the smooth muscle to regularly contract in the epididymis and vas deferens, and that propels the sperm into the urethra. Those same nerves will close the internal urethral sphincter, and that's going to prevent retrograde ejaculation into the bladder. And it's going to cause also a small amount of semen to be released before the ejaculation itself. This can occur during sleep, and that's called nocturnal emission. So emission is the first part, moving from the vas deferens, the epididymis, vas deferens into the urethra. The ejaculation is going to be the expulsion of semen from the urethra, and that's going to really involve peristaltic contractions of the muscles called the bulbal spongiosus muscle around the penile urethra. And what's the trigger for this is going to be when the sperm and the seminal fluids enter the urethra. They're going to trigger sensory nerves that are part of the pudendal nerves to trigger the spinal cord reflex, which will initiate those rhythmic contractions. And so that's going to propel the semen out of the penis. And we think there's sometimes 10 or more of these contractions. Usually the ejaculate is released in the first couple, but even after the ejaculate is released, these peristaltic contractions continue for a little while. Premature ejaculation is ejaculation that occurs too early, such as during foreplay, usually triggered by psychological factors, anxiety, but it could also be very hypersensitive foreskin or glans penis. And the one treatment suggestion is to actually pinch the urethra closed between the glans penis and the shaft as the ejaculation approaches. That can sort of retrain the nerves to not fire quite as quickly. There's different behavioral therapy, relaxation therapy, and then potentially medications to treat this well. So that is the process of erection and ejaculation. Again, erection is primarily under the parasympathetic regulation, whereas ejaculation is under sympathetic regulation. And usually with the sympathetics, we get a release of dopamine, and the dopamine triggers the reward centers in the brain, and that causes a lot of the pleasurable experience. After male ejaculation, there's often a surge of prolactin as well. And the prolactin is actually thought to be part of the kind of refractory period after male orgasm, where there's little interest in further sexual sort of activity for a little while. And we think that has to do with the rise of prolactin. That's going to vary in different males. I'll just mention one final hormone, and that's oxytocin. We think oxytocin is very important for the erection itself, but also for emission of sperm and to allow that process to occur. All right, so that's a basic overview of male reproductive anatomy and basic physiology. In the next little video, we'll look in detail at steroidal genesis and the physiology around testosterone.